We're going to be covering the workup and management of pneumothoraces today. And the first thing that you want to do is assess the patient, and the symptoms that they generally experience are chest pain and shortness of breath. When we see this, we want to begin with our physical exam by listening to breath sounds to the heart, but once that's done, we want to then move on to attaching our monitors. So this includes a blood pressure cuff, EKG leads to monitor the heart rate, and also an O2 saturation monitor to monitor their saturations. The patient is short of breath because they're hypoxemic, and for this reason they'll also be tachypnic and tachycardic. We monitor the blood pressure because if the patient is in shock, this is concerning for tension pneumothorax, and we have a real emergency here where we need to emergently treat the patient. No time for chest x. If we have some time, we want to go ahead and place a nasal cannula and get some supplemental oxygen to the patient. Now this can be given via nasal cannula or a non-rebreather or high-flow nasal cannula. All that matters is that you're getting them some oxygen delivery that's above atmospheric oxygen pressure. The reason why this is important is that not only are you supporting their hypoxemia, but the oxygen also treats the pneumothorax. This is because most of the air that we breathe in is nitrogen. And I won't get into this nitty-gritty, but giving high concentration of oxygen actually causes a shift in nitrogen out of the pneumothorax into the air that we exhale, and thereby reducing the size of the pneumothorax. Once you've supported the patient with oxygen and you have a clinical suspicion for pneumothorax, you want to go ahead and treat. To do this, you can do a needle decompression at the midclavicular line in the second intercostal space, or you can do it at the fifth intercostal space at the mid-axillary line. This chest tube in the triangle of safety, which is bordered by the pec, the lat, the nipple line, and the hairline of the axilla. Many clinicians do get a chest x-ray to confirm a pneumothorax before doing any intervention, but really if the patient is not doing well and you have a clinical suspicion for pneumothorax, you should go ahead and treat. You can always get a chest x-ray afterwards. This goes over the basics of how to work up and treat a pneumothorax in a very conservative fashion.
Can't breathe. I can't breathe. Can't breathe. I can't breathe.
Shortness of breath is better. I can breathe easier now. We'll talk now a little bit about chest tube drain management, what's also known as the Pleur-evac. The chest tube connection is where the chest tube connects to the drain itself. The collection chambers are where any fluid or air from the chest tube will be collected. The chambers slowly fill from right to left on this screen. The water seal chamber will show you if there's an air leak, and its gradual rise and fall will indicate whether or not there is tidling. This is where wall suction will connect to the chest tube drainage system. The suction bellow will indicate whether or not there is suction applied. The bellow, when on suction, will be extruded. In this image here, you can see that the bellow is extruded, and this is what it would look like when it was on suction. Here is clearly on water seal, as the bellow is not extruded. The suction indicator will tell you how much suction is being applied to the chest tube drainage system. Here, approximately negative 30 centimeters of water is being applied. Here's an example of tidling. We can see that the ball in the water level rises on inhalation and then falls on exhalation. The reason for this is that normal breathing is caused by negative pressure within the pleural space. This diagram nicely shows how the pressures in the lung during breathing are negative and the volume changes that occur. This is why the ball rises or gets sucked towards the drain during inhalation. We can also tell that the box is on water seal because the orange bellow is not extruded and we cannot see it in the window. Shortly here we're going to see a little bit of air leak. Yep, and right there we see some bubbles forming in the water seal chamber. The numbers across the bottom, 1, 2, 3, 4, and 5, demonstrate how big an air leak you actually have. You can see here the bubbles are pretty consistent, and now the strength of the air leak rises. So as the bubbles reach further and further across those numbers, it means that the air leak is growing larger and larger and larger. And this is a way to document the change in strength of the air leak over time. So putting that all together, what you'll note is that when you place a chest tube on suction initially, the bellow will be extended out. Here it's on negative 20 centimeters of water pressure, and then when we look down at the water seal chamber, you'll see a ton of bubbles. That's the air from the pneumothorax escaping. But over time, when you come back to check the drainage system, you'll note that the number of bubbles slowly dissipates away and the water level starts to flatten out. You may see occasional air bubble being released here or there, but that's okay. Again, this just means that the amount of air within the pneumothorax has reduced. If you place the chest tube on water seal and there's tidling as shown here, that's a good thing. But what we don't want to see are air bubbles as shown here. This indicates an air leak. So if you see this after placing it on water seal, you probably want to go back to suction and ensure that all the air within the pleural cavity has been removed. So when the system has been put on water seal, we'll see tidling as shown here. There's a little bit of an air leak there, but over time this should dissipate. And really what we want to see before the chest tube is removed is that there's tidling without an air leak as shown here. At this point, it's probably safe to remove the chest tube. So at this point, we would proceed with chest tube removal.